All, this is Dr. Mobeen Sayed from drbeen.com. Hope you're doing well and happy and safe. Let us start our discussion today. We're going to talk about the metformin. This was a study that was tweeted to me by one of the cool beans here. So before we start, quick updates on the cool beans. All cool beans that we have been treating, they have actually improved. There is one sad news. Just half an hour ago, one of the cool beans mother, she was in ICU. They included me in the discussions about 4 or 5 days ago. So she fluctuated. Her doctors were not very comfortable starting ivermectin. She was on dexamethasone and remdesivir. And after they did start eventually, and she did bounce back from there from 89, 90 to 93, 94 oxygen, but she was on high flow nasal oxygen, then on BiPAP, and half an hour ago she passed away. So my condolences to the cool bean, and it's very difficult normally to see these things happen when we could do better, but still at the same time, we all are going to pass away from here. This is just a sad news. So my lecture today, probably a little more shorter. Some part of it near the end, I could not further develop it because I heard this news and I was with the cool bean. So let's start our discussion. The discussion today is about the metformin. So the study here for the metformin, this is a study that was sent to me by a cool bean, I believe, Kobayashi Maru, that is the name on Twitter, who sent it to me. Metformin is associated with decreased 30-day mortality among nursing home residents infected with SARS-CoV-2. So the importance over here is that this is nursing home residents, mostly old age. They have comorbidities and they are at a higher risk. So to find some drug, which is usually used by advanced age folks, and then having that to be useful as well is a very important thing. So if you see here, I have downloaded the PDF, and I saw a comment from Bambi. Can't you have a break and some self-love and family time? Bambi, absolutely. Thank you for that. I feel that at this time, this evil, the pandemic, is such a rampant and out of control thing that we cannot, all of us have to be all in to try to help and try to protect. So everything else is secondary at this time. I know that many of you would say family, love, care is primary and everything else comes after that. For me at this time, I have no other thought in my mind. My business went down during these days, months, because I was focused entirely on COVID and focused on free lectures. Of course, my family sees me daily that I am working, and so they miss me as well. But there is a very larger issue that is going on, and I just do not know how else to help it. And so this is, and I want to thank all those researchers whose researches we talk about. These are not my researches. These are not things I found. I am at most just a vehicle to take their message and present it to you. So that is just like this little pen that is moved by somebody's hand and shows you something in writing. So I am just like that pen. I'm just like that tool who would pick up somebody's work and present it to you. So I'm not even my contribution is not even that great. It is just a translation of one message to you. But still, I feel it is a very important time for all of us to do what we can do. So thank you very much for your care. Let's continue with the discussion. So here, this is the study. This is from Rhode Island. So if I just go to my illustration, here is how the study is done. So this is a retrospective cohort study. So that means they looked back at the patients who, or the nursing home residents, looked at what drugs they were taking for diabetes, and then saw if there was any difference in the COVID-19 mortality. They did this research on the patients from March 1 till May 31, 2020. They had a total of 775 nursing home residents that they used in this retrospective study. These residents were living in 134 communities, which were Veterans Health Administration run communities. And here is the result. It is really interesting. So look at the method first. What they did was the following. The researchers, they looked at all those residents who had become SARS-CoV positive or who became COVID-19 positive. So let's say they became positive here. Then what they did was they went for those patients who had become positive. They went back in their record and they looked at what drugs they had taken for diabetes. So of course, there were people who had taken Metformin. There were other folks who were on insulin. Then there were other folks who were on other drugs. Metformin is the first line drug, but there are many other drugs for diabetes. And then there were those as well who were either diabetic and not taking any drug, or who were not diabetic and not taking any diabetes drug because they were not diabetic. Cool. So let's now look back at it. So let's say somebody becomes infected, confirmed infected here at this point. Then they go back and they look at their charts to see what drugs they were seeing. Then they start observing them for the next 30 days to see what is the outcome in them. And they wanted to understand was that within 30 days, what is the mortality rate, death rate in various patients who were on various drugs. That was what they were looking for. And the results were really interesting. Here are the results. Metformin compared to those who were not treated or those who were not diabetic. So in the same community, of course, there are people who are not diabetic, or there are people who are diabetic and are refusing to take the medicines. And then there are people who are taking medicine. So they took this group of Metformin users, and then they took those who were not taking any drug. And here is the hazard ratio. Here is the hazard ratio, mean the risk of hazard, whatever that is, risk of an adverse event. In this case, the hazard ratio is about the risk of death. So the hazard ratio was 0.48. So if I go here, so if you see here, results relative to those not receiving diabetic medicine, residents taking metformin were at significantly reduced hazard of death. Adjusted hazard ratio was 0.48. So here it is 0.48. What that means is you subtract 0.48 from 1. So that gives us, let's say, 52 or 0.52. So that means 52% less likelihood of death, or 52% less chances of death. So the hazard ratio was 0.48. And if you look at the confidence interval, that would tell you if this ratio was significant or not. And you know that you have to make sure it does not cross the unity. So here it does not cross the unity. It is from 0.28 to 0.84. So how do we interpret this? Number one, it is a significant result. Why it is a significant result? Because confidence interval is showing it. And the hazard ratio is 0.48. That is also important. And the clinical outcome is also significant because this is what we're talking about, death. So how do we interpret this data, this mathematical formula here? So what we say is patients are 52% less likely to die if they are taking metformin compared to those who are not taking metformin. And we are 95% confident that the true value, so we are saying that they are 52% less likely, but the true value is going to be between 16% to 72%. What does that mean? How do we get that? So 0.84 is, if you subtract 0.84 from 1, that is 0.16, and that is 16%. And if you subtract 0.28 from 1, that is 70.72, which is 72%. So the real ratio is between 16 to 72%. So the likelihood of reduction in death is between 16 to 72%, and we have a mean of 0.48%. So that is a significant outcome. Now, if we compare that to other groups, so remember there were 4 groups. One group was on metformin, we just saw the results. The second was on insulin. So here is the insulin group. So when they compared the group that was taking insulin compared to those who were not treated or not diabetic, the hazard ratio was 0.99. So if you subtract that from 1, that is 0.1. So we are saying that there is a 1% chance of less, there is 1% less likelihood of death. Excuse me, that in itself is not significant. But then if you look at the confidence interval, that crosses the unity as well. So it is from 0.6 to 1.64, which means from 40% to minus 164%. So this actually crosses the unity, so it is not significant. So that means patients on insulin had no benefit towards COVID-19. Then patients who were on the other diseases, other drugs, so many other drugs for diabetes, the hazard ratio was 0.71. So that means they were 29% less likely to die of COVID-19. However, the confidence interval crosses unity, so 0.38 to 1.38, which means it is not significant. So this was also not significant. And finally, so let me just at least review it. What we're talking about is that in the nursing homes, those patients who were taking metformin, they had 52% less likelihood of dying within 30 days of contracting the COVID-19. And this data was significant. And this phenomena was not seen by other diabetes therapies. So insulin was not doing it, or other drugs were not doing it. This was specific to metformin. So why is it that metformin may be doing something here? So let's look at metformin from a very high level. Metformin is one of the biguanides. This is the only drug that is in the class of biguanides, and biguanides are the first line therapy for type 2 diabetes. So generally, how do they work? I have a long lecture about insulin and metformin. Here, just a very high level discussion. Metformin activates an enzyme called AMP-dependent kinase. That enzyme in the liver then causes reduction in gluconeogenesis. What does that mean? When we are going, let's say, from lunch to dinner, between that time, there comes a time when we are actually kind of starving. We do not have enough glucose left. Why? Because when I take lunch, or when you take lunch, then what happens is within 2 hours, the glucose which is extracted from the food has been sent into the cells. And then we do not have enough glucose, but we want to keep a specific level of glucose in our blood. So what liver does is it takes up and makes new glucose. And there are many mechanisms to make new glucose. So that is called gluconeogenesis, new glucose formation. And for that, this enzyme AMPK, or AMP-dependent kinase, is very important. And metformin activates that enzyme. That enzyme in turn inhibits gluconeogenesis. So this is how metformin tells the liver not to make more glucose. In addition to that, metformin increases the glucose uptake by peripheral tissue. So our muscles and other peripheral tissues, it tells them to take up glucose, and then they eat up the glucose, and the glucose amount in the blood is reduced. Remember, in diabetes, the objective is not to reduce the glucose in the body. We want the glucose to go in the cells and do its function. We just do not want the glucose to hang around in the blood and in the tissues, because over there it is going to cause non-enzymatic glycation, or just like mud. Imagine lots of mud on the streets, and it's going to just cause the streets not to function correctly. So imagine the same thing, lots of mud on the tissues, and now tissues cannot function correctly. For example, epithelium of the respiratory system in COVID-19 is very important to throw the COVID-19 and the sputum out, the phlegm out. And if there is glucose which is hanging with the epithelium of the cells and the cilia of the cells, the cilia cannot beat anymore, and they cannot remove the virus easily. So glucose hanging around on the cells causes a lot of damage. Glucose also causes damage by osmotic pressure. So that is why the eyesight issues appear. Then glucose causes small vessel damage. Glucose causes nervous system damage. So there are a lot of things. That diabetes is one of my favorite topics. On Drbeen.com's main homepage, if I can just very quickly show you, here I have a free lecture here, classification of diabetes mellitus, and then inside in the premium content there is a lot more discussion about diabetes. So coming back here to this discussion, so glucose uptake is very important. If we get the cells to take up the glucose and the glucose is reduced in the blood and in the tissue, then that is a good thing. But we don't want the cells to starve and not have glucose at all. So metformin helps with the tissues to take up the glucose. Then it increases the insulin sensitivity. Insulin is like a doorbell. So it goes to a cell and then connects with the channel over there, or a receptor over there, which causes the cell to open up glucose channels and get the glucose to come in. So insulin is like a servant for glucose. When glucose wants to go into the cell, insulin is going to sit outside and kind of press the doorbell for the cell to open up. So sometimes what happens is in type 2 diabetes, it is the peripheral insulin sensitivity that has reduced. That means that imagine in the doorbell. So let's say outside your home is a doorbell and somebody has to press that to allow the glucose to go into the cell. And imagine now we throw a lot of mud and fats and things in that doorbell, and you try to press it and it does not function anymore. That is what happens. In the peripheral tissue, insulin sensitivity reduces and the cells do not respond to insulin to open up their doors to get the glucose. So metformin would help increase the insulin sensitivity. It also increases the fatty acid oxidation. It also reduces the glucose absorption from the intestine, which then has one more benefit. When we do not take up too much glucose from the intestine, then glucose stays in the intestine and continues on and is removed from the fecal route. In that process, it also changes the microbiota of the GIT and kind of changes their behavior as well, because they have more glucose to work with. And of course, this would cause more gas as well. And then finally, it reduces glycogenolysis. So glycogenolysis means what? There is glycogen. Glycogen is stored form of glucose present everywhere, but mostly in the liver. And so when liver wants to make more glucose, it can actually just break down glycogen and make glucose from it. And metformin would try to reduce that as well. So these are all the discussions for the glucose part of the mechanism. However, it is a very important part of metformin for immune regulation, and that is its action through mTOR inhibition. And I'll explain what mTORs are. So mTORs are proteins present in our cells that are then in turn going to work with the cells and immune system's behavior. And nowadays, there is a lot of interest in understanding the mTOR's behavior for cancer. So metformin has been a drug that has been seen to see if this can actually work for cancers as well. So what happens is this. In this study, they say, so if you see here, these findings suggest a relative survival benefit in nursing home residents on metformin, potentially through its mTOR inhibition effect or inhibitory effect. So let's see. When the mTORs are proteins inside the cells, and these proteins take part in certain cell functions. So for this correlation here with this study, number one, when mTORs are inhibited, when they are suppressed by metformin or other mTOR suppressors, for example, rapamycin, which is an immunosuppressant. So rapamycin is an immunosuppressant. Same is true for metformin as well in correct doses. So what does it do? When mTOR is suppressed, viral protein production is reduced. Remember that the virus has to come into our cell and make more copies of itself by making its proteins and then processing them, maturing them, and then kind of assembling them together. So production of protein through our ribosomes is reduced. Then processing of those proteins and maturing them, that is reduced. And assembly into a new virus is reduced when metformin has suppressed mTORs. That is one function directly useful. Then another important function is that mTOR inhibitors like rapamycin, and this may be the same thing that is happening with metformin. What they do is that, remember interleukins, we've been talking about interleukins for a long time. Interleukin 1 and 2 and 3 and 4 and 6, and right, all of those interleukins eventually go to various immune cells and cause them to proliferate and cause them to function and cause them to aggregate, and chemotactic factor comes in and they come over the site of infection and they do their function, correct? Metformin or rapamycin, for example, will sit between the cytokines and the cells, T cells especially, and will not let the cytokines affect the T cell. So T cell proliferation and T cell activation is reduced by rapamycin, and that is a similar function that metformin is potentially doing. So this is the basic discussion. My apologies that this last part I could not draw it up more elaborately because of the news that I had and I was talking with the cool bean. But I wanted to make sure that we can look at this study together. It is a very interesting study, especially why it is more interesting for me is that it is in the old age, many folks are taking metformin. So there is a possibility of an inherent benefit against COVID-19 as well. So this is the discussion for today. I hope that you're all keeping safe and healthy. Please, with the things like today, it just tells me that keep protecting yourself. Don't let your guard down. If in our culture, if we say that if somebody's time is up, then it is up, we cannot do anything. But still, don't let your guard down. Keep your masks on, wash your hands, have your social distance, do whatever prophylaxis we can, do whatever help you can for yourself and others, and don't relax. Stay vigilant, please. Cool. So this is the discussion. So I would see you tomorrow. Sorry, not tomorrow. Tomorrow is my off. So I'll see you on Monday. Thank you very much. If you would like to help me, please like, subscribe, and share this one. There is a link in the description as well to support my work. Thank you. Bye-bye.